Welcome to the latest episode of Lateral Think, brought to you by Melbourne Athletic Development. Melbourne Athletic Development is a sports and injury management clinic based in Melbourne, Australia. To maximise your performance, optimise your injury management, contact the team at Melbourne Athletic Development. As many of you know, Jack and I have a very diverse understanding across multiple areas of practice, whether they relate to sports performance, say for instance with my background in track coaching, or with Jack and his background in yoga practice. We've combined a lot of this knowledge over time with our clinical and sports performance experiences to really develop what we do. And as you know, we love education. So what we've tried to do is take that knowledge and put it into an online learning community. We think this is important because it's an opportunity for people to interact, learn, and upskill as they try to improve the practice of what they do. So if this is something that you would be interested in doing, head to melbourneathleticdevelopment.com.au/education and get an understanding of how you can upskill your current practice.
Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Today I'm very glad to have with us Professor Carla Stecco. Carla, thank you for being here today. Could we start with you giving us a background of who you are and what you do?
Thank you, Jack, for the kind invitation. It's really a pleasure to stay with you and to speak about fascia. I'm an orthopedic surgeon and a professor of anatomy at the Padova University. And there are many years that I'm studying the fascia from macroscopic, microscopic, ultrasound, and clinical point of view. I'm the creator, together with my father and my brother, of the fascial manipulation technique, and I'm strongly involved in the understanding of the role of fascia in myofascial pain, proprioception, motor coordination, performance, and consequently, I'm glad to discuss all that element with you.
I think a good starting point is to talk about where this interest and passion came from. And we've had your brother Antonio on the podcast before, and he's told us a little bit about it. But I think it's always interesting to discuss it because it's very unique in the sense of the path that your father has taken, and very much so the ingenuity and innovation he's taken to create this particular method, because it is very novel and it starts to integrate an area of anatomy and tissue science that even to this day is actually often forgotten about or neglected.
Yes, I think that my father was really a genius to understand that the potentiality of fascia and how to create a biomechanical model that allow us to understand how fascia work. So for all my life, I heard about fascia and also I see the result in the patient with fascial treatment. So I decided to do medicine and then orthopedic surgery just to understand what the classic medical courses know about fascia. And at the end of my courses, I understood that nobody know nothing about fascia. So I had the opportunity to start to do research myself about fascia. And I think that for that reason, I'm probably one of the first that started to do research, scientific research inside the university about fascia. Because before there was just my father, Rolf, Dick, Meyer, other people that tried to understand fascia, and they did an incredible work in the clinical aspect to understand how to treat fascia,
Mm.
why fascia are so important. But now we have also all the anatomical basis, the microscopic basis to really support a manual treatment into the fascia.
That brings me to my first question, and that is about the particular method that you have pioneered or at least reinvigorated, and that is about how you dissect the human body. Because from my understanding, and I think back to when I was at university, when we look at a cadaver, muscles look independent. They have this clear origin, clear insertion. All of the fascia, in particular the aponeurotic fascia, is removed, and it creates this really nice, highly organized image of the human body. But that is also problematic. Could you talk a little bit more about that and the particular methods you use to dissect the body and how that influences our understanding of the musculoskeletal or myofascial system?
Yes, I was probably lucky because when I started to do this section, I was totally alone. And
Mm,
consequently, had the opportunity to try many different ways to do this section in an alternative way. So without follow all the traditional rule that suggest to remove all the connective tissue to visualize well the muscle, the nerve, the vessel. But I had the opportunity to start with a very open mind and to try to understand what is the best way to visualize the fascia and the continuity that the fascia permit among the different muscle, nerve, vessel. And consequently, I create a new method to do the dissection. And now I have some colleagues of anatomy that are asking me to create a new protocol to dissect the fascia, to change the perspective, to highlight more the continuity and without remove the element that allow that continuity. So surely is a change of perspective. And I think that we have a lot of work to do to classify and to understand well all that continuity. But what is sure is that the fascia have a very precise anatomy. Is we have some connection that are always present in the same point, that connect always in the same way the different muscle. So
mm,
we need to understand that the connection and the organization of a fascia is very precise, and only if we understand that specific anatomy, we will be able to interact with the fascia in a very effective way.
mm. I think the thing that you highlight there too, that I think is important, is a lot of the time when we hear the word fascia, everyone talks about it's everywhere and it connects everything. But although that may somewhat be true, it's probably a bit misleading and I think misinformative because it makes us think that there is no particular specific paths or, like you said, like particular connections that are consistent in person to person. But that's actually not the case. We actually need to really explore fascia more specifically so we can understand the more specific connections and therefore the influence that has on things like force transmission and locomotion.
Exactly. So is surely nice the picture that the fascia connect everything everywhere, but
Mm,
it's not exactly true. So the
mm,
fascia is a three-dimensional network that create a huge connection through the body, but follow a precise rule. So we have some point that are more connected respect to other point. We have some line of force that transmit the force of the muscle, the tension of the fascia in a precise direction and not in another one.
mm,
And only if we understand that the precise architecture, we can really interact in an effective way with the fascia. Otherwise, we can just give some input, but probably is not so effective, has not a so strong impact as knowing the exact anatomy.
yeah, and I can appreciate that that then starts to have big implications for how different areas of the body influence each other. You know, like I think of a common one that has been well described in some of your literature is the continuity of the gluteus maximus through the lateral intermuscular septum and the iliotibial band, and obviously how that has a big influence on things like stabilization of the knee.
Of course, of course. And also that is a clear anatomical support that suggests us that every time we have pain in the lateral region of the knee, when we have knee instability or knee rigidity, we can also check the gluteus maximus and the gluteal area, because the fascia create a huge connection between the two parts of the body.
Mm.
And consequently, from a clinical point of view, many people know that connection, but the fascia now are able to explain that connection and why the lateral part of the knee maybe is more affected with respect to the medial part of the knee.
Mm. The other key area I think about that has a lot of mystery surrounding it is low back pain. And, I often, when I think about low back pain, the classification system we typically think of is more related to the articular or joint system. So, in terms of discogenic pain, facet pain, um, but the other key structure that is there is the thoracolumbar fascia, which has quite an elaborate and complicated anatomical connection to muscles that connect the back to the upper body, but also to the lower body. And it's something I've actually been looking a bit more into recently, of some of the changes within the thoracolumbar fascia in chronic low back pain, but that which highlights its involvement in pain itself. But I think from an anatomical standpoint, it starts to make you think, well, is it about just treating the thoracolumbar fascia itself, or other anatomical structures that connect to it and that are going to influence the tension put through it?
Exactly. Indeed, we need to remember that still now, more than 80% of the back pain is classified as a specific back pain.
Mm,
So it means that really the imaging is not able to explain the origin of the back pain. I think that all that part need to be subclassified and to understand the role of the thoracolumbar fascia, but as you underline, generally of all the fascia in back pain, because the thoracolumbar fascia is a very strong and big fascia that create a good support in the back area and surely could be directly involved in back pain. We start
mm,
to have some evidence about. But what we need also to remember that the thoracolumbar fascia is like a big sensor that feel the tension coming from the inferior limb because it is stretched by the gluteus maximus. Feel the tension that come from the upper limb because it's stretched by the latissimus dorsi. Feel the tension that come from the abdominal wall because the thoracolumbar fascia give insertion to all the oblique muscle and the transversus muscle. Feel also the tension that come from the neck because all the erector spine insert in the inner side of the thoracolumbar fascia. So everywhere we have an unbalanced condition, maybe can stretch the thoracolumbar fascia in the wrong way. And
mm,
the thoracolumbar fascia is incredible innerved. So a bad tension can create pain. What is the main problem in the clinical practice? That wrong tension can create huge pain, but when I check the thoracolumbar fascia with imaging, the thoracolumbar fascia is not altered because
mm,
it's just doing its work. So is feeling a wrong tension, and consequently we need to move far away from the back and to check all the structure that are stretching the thoracolumbar fascia and understand if the tension is correct or not.
mm,
So, to resume, we can affirm that we can have a primary problem in the back, but also just an alteration in the tension that origin far away from the tension and is transmitted in that area through the fascia.
mm. Something I often ask myself and I scratch my head when I ask myself this question is, why have we forgotten or at least dismissed fascia, generally speaking? Like, from an anatomical standpoint, it doesn't really come up. But again, I think about even the language that we use within anatomy. Fascia is something that doesn't really get discussed. We hear all the time about muscle, we hear all the time about nerve, ligaments, bone, but fascia is very often dismissed or forgotten about. Why is that?
Yeah.
Why do you think it's not a topic of conversation, considering that there is actually quite an abundance of research?
I think that I know that there was a very nice description of fascia in the first edition of Test Tube, Pature Gray's Anatomy. So the big anatomist did the description of the fascia, above all of the deep fascia, but also of the superficial fascia. I remember that Sterzi, that was an anatomist at the Padova University, in 1910 published a book only about the superficial fascia.
Mm,
But they were not able to give a function, so they give just an anatomical description, but they were not able to understand what is the function of the fascia. So, in the following edition, the description about fascia was cutted because the people were not able to understand why we need to study some tissue that is just a cover, is just something that is not really important for to understand the locomotor system. So, in the simplification of anatomy that we did in the last century, because of the book became smaller and smaller, the number of lecture at the university about fascia became smaller and smaller. So all the professors were focused to give the key concept of fascia, of anatomy. They decided that probably fascia is not important because there are no function.
mm,
Now we are rediscovering the fascia because now we know what is the function. We are understanding the role in proprioception, in movement, in pain, and consequently, we need to rediscover it. It's not something new because really the description of the past were pretty good.
mm.
But we are adding a more clinical point of view.
One thing that you mentioned there too that I think is worth discussing is the function of fascia. But in order to do that, we need to really think about what particular fascia we're talking about because I think a lot of the time too, when you hear about fascia, they classify all different elements of fascia within the same basket. But as you mentioned, then we need to think about superficial fascia versus deep fascia, and perhaps even maybe think about uh, visceral fascia too as being different again. Can you actually explain how you classify them as different and what roles that they have? What are the specific characteristics that they have that make them different?
Oh, that could be a pretty long and boring lecture. But
Well, I know I'd find it interesting.
generally speaking, but we need to remember that we have, I think that we can speak about the fascial system. So the
Mhm,
fascial system is like a big basket that collect all the different fascia, but also the ligament, the capsule, the tendon, the
mm,
interstitium. So all the elements that allow the continuity through the body, allow the sharing mobility, allow the transmission of the force. Then inside that basket, we need to subclassify different organ. And for
mm,
me, we have the superficial fascia that is an organ that organizes the subcutaneous tissue, organize the fat of the epidermis, the lymphatic vessel, the superficial vein, the superficial nerve, and is strongly related with the skin trophism, the vascular thermoregulation. Then we have the deep fascia or the muscular fascia that are related with the muscle, the bone, the joint. and is the element that is more related with the movement, with the proprioception, with the motor coordination. Then we have another organ that are the visceral fascia. The visceral fascia are the element that support the organ, that create the shape of the organ, but also allow the different organ to move in an autonomous way. Remember that, for example, in the thorax, we have the esophagus that has a peristalsis, the heart that have a specific rhythm, the lung that have another rhythm of movement. So all the different organs are in a very close space, but they have autonomous movement.
Mm.
And that is allowed by the fascia. Without fascia, without the gliding between the different fascia, each movement can interfere with the other organ and can create pathology. So also the visceral fascia have also a specific autonomic innervation that interact with the organ to allow this different organ motility, the different function of the organ. And finally, we can also consider the fascia around the brain as the meninge, that for me is another fascial organ, and the fascia around the peripheral nerve that allow the nerve to move and to be autonomous respect to the surrounding tissue.
Something that you mentioned there is the importance of independent or autonomous movement, whether we're talking about the muscular fascia or the viscera. This is something that, I mean, again, thinking back to my training at university, is never really discussed, but it's something that is actually really important. Can you actually describe, maybe even just starting with like the deep muscular fascia, that why it's important to have autonomous or independent movement of different layers of tissue?
Yeah, that is a key concept when we think about a muscle because a muscle never contract all together, all the the fiber together, but the different bundle need to contract more, less, stronger, and only if the different bundle can glide each other, we can have a very fluid movement, a very nice movement. Otherwise, we have a group of fiber that contract all together and create a very alterated movement. But think also that to organize a movement, we need to have the synchrony of motor unit that are in different muscle. So maybe we have a portion of a muscle that contract there, another portion that contracting another part, and we need to coordinate that movement. So the fascia has really an incredible work in that because it permit the autonomous movement of the different bundles inside the muscle, but at the same time create the bridge between different motor unit that are placed also in different muscle.
Mm.
And thanks to that type of separation and connection, we can really have a very good movement.
There's a few things you said there that make me think of a couple of things, and one of them is um, when you think about neuromuscular behavior, each muscle has hundreds, if not thousands, of muscle spindles and associated with that motor units. And how they are recruited is simply too complex for us to be able to comprehend from like like a mathematical standpoint. Perhaps some type of supercomputer could do that. But it's one thing that I think about because a lot of the time you hear this language of we need to do this exercise to get this muscle to fire. And I think that is associated with the idea of the whole muscle contracting. Yet that's actually not reflective of what's happening. How I create movement is a very fine process of certain motor units working, certain motor units not, and that probably changes from time to time each time that I do it too. Because I imagine from a energy conservation standpoint, it's not really effective to use the same pattern time and again. What role does the fascia have in providing feedback to our sensory motor system to be able to help coordinate the contraction and coordination of muscle?
Oh, another huge question. So the
I
fascia
don't waste my time on any small questions, Carla.
So the fascia is, for me, the organ of proprioception and motor
Mm,
coordination. What means that inside the fascia we have a huge network of free nerve endings, but also the muscospindle. We have also the Golgi corpuscle, some Pacini and Ruffini, and all the organs, that nerve organs, are totally embedded into the fascia. So they feel the fascial tension and can fire or not according with the environment. Think about the muscospindle. The capsule of the muscospindle is just a splitting of the perimysium around the intrafusal muscle fiber.
mm,
So it's nothing different. And we demonstrate that in patients with back pain, for example, the muscle spindle have a thicker capsule, have a much more connective tissue around. But also in patient aged, the capsule is much thicker. What means that when we need to contract, usually we need to trigger the muscle spindle that have to shorter, but also in the postural control, the muscle spindle need to elongate, to shorten. So the muscle spindle need to change the shape. But when we are, the muscle spindle are in a very rigid fascia, much thicker because there is more connective tissue, the strength that we need to change the shape of the muscle spindle is much more.
mm,
And that can create a lack of activation of the muscle spindle. So a lack of proprioception, a lack of ability of the muscle spindle to permit a correct motor contraction, a correct muscular contraction. So we need to understand that the movement can allow only in a very integrated way. So we need to have a good muscle, because if the muscle is weak, surely we have not a good contraction.
mm,
But we need to have good sensors. So we need to have a good free nerve endings, a good muscle spindle, and we need to have a good fascia around that allow the muscle and the muscle spindle and the free nerve endings to work in the proper way.
mm,
I also think that the fascia is like the peripheral map for the brain. So when we contract and we stretch a specific portion of the fascia, all that the free nerve endings, the Golgi, the Pacini, the muscle spindle that are in that part of fascia have a specific trigger to the brain, and the fascia is like the mirror for the brain. And only if the two elements feel in the same way, we have a good perception of the movement.
mm. You actually, when you talk about the messaging that the fascia provides to the brain, it makes me think of, I'm lost for his name now. There's a neuroscientist at Harvard University, a British guy. I can't think of his name right now, but he talks about this idea of the sensory motor system having a state estimator, so your brain perceiving what should happen, and then the actual data feedback of what is happening. And that when you start to see that mismatch, that's when you start to see problems developing, whether that's, an injury or the development of pain because of that um, mismatch
I
between what's
totally agree.
happening. Mm.
I totally
Uh,
agree. I think that really is mm, our pain is often a mismatch between what the brain expects and what the fascia feel really, and
I
that
just,
can
no, go, please finish.
and that can trigger problem in the motor coordination, but I think also in the pain perception.
Mm. I remembered his name. His name is Daniel Wolpert. I don't know if you've ever heard of him. Um,
I don't know him, but
uh,
I read something about, and
yeah.
I agree totally.
So then this takes me back then to thinking about the importance of the independent gliding of different tissue layers, that in order for the sensory or proprioceptive function of the fascia to work, it needs to be able to have that autonomous movement so those free nerve endings are providing a right signal of the tension that's being created with specific complex movements. Would that be correct?
Mhm.
Mm,
Sure. I think that think about almost all the muscle. We have two surface that
mm,
need to glide one respect to the other. In the two surface, we have the nerve endings. Without that gliding, every time one muscle contracts, stretch also the other fascia. So we
mm,
have two input that arrive to our brain when we need only one input, only the input of the muscle that is contracting. So we need to have the isolation of the two layer to allow a good perception of the movement. And that isolation is allowed by the loose connective tissue with water hyaluronan that allow the gliding between the two layers. We know also, working with the anesthesiologist, that in many parts of the body we have very good gliding between the different fascial layer. But after surgery, trauma, or also for overuse, we start to change that gliding, and we can visualize that changing with the ultrasound. And I think that one of the key target of the different fascial treatment is to restore that gliding in the best way as possible.
mm. And I think the other thing too, that where you start to get changes in the loose connective tissue is also underuse. The issue we have of not doing enough physical activity and creating that typical gliding between different interfaces to maintain normal biochemical structure of the loose connective tissue.
Yes, surely the movement play a key role to maintain the movement and to stimulate the production of hyaluronan.
Mm,
But the movement stimulate also the better organization of the fascia, because the tension stimulate the production of collagen fiber according with the direction of the movement.
mm,
So what for me is important in the future is also to understand how movement affect the different element of fascia, because affect the gliding, but affect also the fibrotic part of the fascia.
mm.
And we can interact with the two part in different way, using different type of exercise, different mechanical input. And is important to remember that every time we think to train a muscle, we are giving also a mechanical input to the fascia. And
Yeah.
that mechanical input could be good or not, because if we are not awake about that, maybe we are just creating a rigidity into the fascia that then can create a problem at our muscle, because if the muscle is enveloped in a very rigid fascia that is not gliding and so on, can don't not is not able to contract as he can, because the environment is wrong. So the exercise could be very powerful, but in both the direction we need to pay attention.
Yeah, and that's an area that I've tried to look into before, of understanding adaptations of fascia to different types of exercise stimulus. Because when I think of, say, muscle, it's obviously been very explored in detail and in depth. And like as you alluded to, when you're contracting muscle, you're and applying tension to it, you can't separate that out from the fascia, particularly the epi, peri, and endomysium. But then we need to probably think about how we influence the aponeurotic fascia. Maybe that's a little bit different. Is there much research out there that helps us to understand the adaptation of fascia to exercise?
Unfortunately, there is very few research about that. What I can affirm, but are more clinical study and not really basic science study, is that surely the fascia is able to answer to the mechanical input.
Mm,
We published a paper about the cell of the fascia that answer to the shock wave, for example, producing more hyaluronan. So we can affirm that probably the mechanical input can stimulate the production of hyaluronan. We
mm,
know that the mechanical input are able to stimulate the fibroblast to produce more collagen fiber. So we know something, but nobody until now has studied exactly what is the best way to train the fascia. And my impression is that we need to have a different type of training according with the purpose that we want to reach. If we want more gliding, if we want a better coordination, are different type of training.
And that also, I think, highlights a really important point because I personally stay away from social media, but I've heard of people having debates on social media about things like foam rolling for the iliotibial band, and people saying you can't lengthen the iliotibial band. But it's not just necessarily about, for instance, changing the length or characteristics of the collagen, although that is important, but also the chemical structure or the extracellular matrix of either the fascia or the loose connective tissue. Do you think that's an appropriate thing to highlight?
Absolutely. We probably the foam roller is not really able to change the fascial structure. We need to remember that the fascia is not a plastic tissue, it's very resistant to the changing. So what we can change probably is the loose connective tissue that allow the gliding. We can change the amount of hyaluronan, the hydration. We can allow a better gliding probably because that part of fascia is much easier changing. We can change much easier respect to the fibrotic part of fascia. But at the same time, also that changing is not permanent. But if we are able to just improve a little bit the gliding and the movement, then we can. I think that the foam roller, for example, work like to improve the washout of the fascia, so we can remove much faster all the waste product. We can increase the water changing, some hyaluronan changing, and that allow to maintain a better fascia respect without a foam roller. But again, we need to be very precise when we speak about exercise, foam roller, manual treatment, because we have a different type of fascia, different element inside each fascia that answer in different way to all the different mechanical and chemical input.
Mm.
So, more I study the fascia and the more I think that are really complex and we are just at the beginning of the understanding.
Yeah, well, look, one other thing I think about too is the impact that different types of manual therapy can have on the fascia. Because, again, I think back to my training where manual therapy all gets sort of lumped into the one category. And most of the time, the explanation for what manual therapy does is it's purely neurophysiological. That is, you're providing some afferent feedback that then causes a relaxation or a reduction of tone of the muscle. And that obviously is one well understood mechanism. But then I think about the value and effect that manual therapy can have if you're applying to, say, the deep fascia on changing the biochemical structure of the loose connective tissue, or, as you mentioned before, similar to something like foam rolling, perhaps facilitating fluid dynamics that can help to like say wash out the accumulation of metabolic byproducts from exercise or what it may be. And having that understanding really helps us to think about the application of different types of modalities to facilitate the health of the fascial network.
Exactly. I published an editorial about that. So I think that to understand manual treatment, we need to come back at the anatomy. We need to understand in what layer we are working with that specific pressure, what is the layer that we are reaching, what characteristics have that layer, and what happen in that layer if we apply a slow movement, a hard movement, a slow force or a stronger force. So we need to be to subclassify the different manual treatment. I think that one of the problem of manual treatment that are not able to show their strength is that we want to consider the manual treatment altogether, but they work in a very different way. They can work in the superficial fascia, they can work in the deep fascia, they can work in the joint capsule, in the muscle, in the bone. So we have many different type of manual treatment that have totally different target. And
Yeah, and
only
let's go on.
if we understand exactly what is the best manual treatment for that specific target, we can try to understand the effectiveness of the different manual treatment.
Mm. Yeah, I feel like manual therapy often gets hard done by, and I compare it to exercise where we don't classify all of different types of exercise into the one domain, yet we do that for manual therapy. And I think part of that, though, too, and it seems to be dependent on where you are in the world and what training you did, that there's a real shift away from manual therapy. At least I see that here in Australia. And so it's all put into that, all lumped together and almost put into that too hard basket. And so um, there's not that opportunity to explore different types of manual therapy, the impacts that it has, and the potential benefits it can have to different types of presentations.
Exactly. I was convinced to study fascia looking at the result of my father in his office. I understood that for back pain, for many myofascial pain, the manual treatment can really work much better respect the traditional orthopedic treatment that and so I really support the manual treatment and a better understanding of the manual treatment. But as a manual therapist, we need to be much more precise in the description of what we are doing. We need to be to understand better the indication. So we need to do a very precise work to highlight all the potential of the manual treatment.
Yeah, absolutely. I I find it interesting too that if you look in elite sport, professional athletes, manual therapy is actually used a lot. Yet typically in like in a lot of other different settings, it's not. And I find that an interesting insight as well because clearly a lot of uh, manual therapists working with elite athletes and athletes themselves see the benefit in it.
Yes, but if I ask you if they are applying a very light or deep massage, if they are working in a big or small surface, what
Mm,
type of force they are applying, in what direction, and so on. Probably all that manual therapists are working a different way, and we have no idea what is better for that
mm,
specific athletes and for that specific problem.
mm,
So With the exercise, I think that in the last 10 years we did a much better work because we understood if it's better concentric, eccentric exercise, static or dynamic stretching, what submaximal strength or more middle intensity train. So we try to compare and subclassify the exercise to focus for each different problem what is better. But actually, that still lack in the manual treatment.
Mm. And I think the other part of the conversation comes back to what we can actually feel with our hands, because that is a skill itself. And from my experiences, I learned more about manual therapy and using my hands about what we can feel. And that's actually a question I wanted to ask you, because one of the obstacles I see with understanding something like myofascial pain, where we get changes in the sliding of different fascial layers, likely because of changes in the loose connective tissue, that's something that clearly we can feel. What about quantifying it though? Because I feel like one of the obstacles at the moment for the concept of myofascial pain to be better adopted is the ability to actually visualize and quantify it. Do you see progress in that area?
All the different group of research are looking for quantify the
Mm,
gliding, quantify and fascial alteration, because surely is a key topic to highlight the fascial alteration. Also, NIH published two different grants to look for quantify to measure the fascial alteration. So that is a very important topic. But what I wanted to underline, at least in the clinical practice, without a specific aim in the research, is that the hand could be really powerful in the perception of the patient problem. And we need to come back to use the hand. I
mm,
speak as a medical doctor, and I'm really disappointed that we have the demand all the diagnosis to the imaging, and now the medical doctor almost don't touch the patient because we think that the imaging is more powerful respect to the hand. I think that is not true. I think that with the hand we can really give a huge screening of our patient. We can really understand a lot about the patient. And then we can help and we can add some imaging. But when I see patients that arrive with the MRI of all the spine from the neck until the sacrum, with MRI of the hip, of the knee, of everything, because they have pain,
mm,
and nobody started to do a good examination, but just prescribe imaging of all the segments that are complaining pain, is something wrong
mm.
because we lost an incredible opportunity to have a better evaluation of the patient, just do a good palpation.
Yeah, and particularly considering we have such good understanding of the amount of, or very often the poor correlation between investigations and someone's actual pain or presentation, the use of radiological studies should be to confirm a clinical diagnosis, not from, oh, you've got pain, let's see what comes up on an MRI or an X-ray.
Exactly. Also because when we started to do in such a way imaging, MRI, CT, ultrasound, maybe we found a lot of element of alteration that
Mm,
probably are not really related with the pain. I
absolutely.
see last week one MRI that was really a disaster
Mm.
and the patient have no pain. So the MRI could be really good for
Mm.
many, but only if we have at the beginning a good clinical examination. Otherwise, we just convince the patient to have many other problems in area that he never had pain, just because we prescribe examination without a clinical examination.
Mm. Mm. Yeah, and again, there's not a lot of appreciation for what we can feel and assess with our hands. And so I think by default, going to something like a radiological finding is something that people like. And I think also, too, people love to be able to visualize things. They love to be able to see a scan and see, oh, I have disc pathology or I have some, meniscal degeneration. Whether that's actually
Yes,
relevant to their presentation or not is another question.
yes, but I understand the patient, but as we as a medical doctor, physiotherapist, we need to guide the patient in that process. We have not to give or to prescribe examination only because in such way the patient is happy because he want the examination. Is not our role.
No, no, that's absolutely true. One question I wanted to ask you, this goes back to discussion about fascia as a sensory organ, is the myofascial expansions. So the fact where we actually see connections of the muscle to the aponeurotic fascia. Can you actually explain what that is? And do we see myofascial expansions that are consistent from person to person?
Yes. Allora, we have the fascia that is an incredible network of fiber, and that network is stretched in specific point by the myofascial expansion that are like a tendon that origin from the muscle but move to the fascia and not to the bone.
Mm.
So every time we contract a muscle, we have always a bone movement because we have the tendon that move the bone, but at the same time, and we can't divide that, we have the myofascial expansion that stretch a specific portion of fascia and create an action into the fascia. The action is in the fascia itself, stretching a specific portion of fascia, and that work like a bridge, creating a spread of the muscular tension,
Mm.
but at the same time work in the nerve network inside the fascia, creating a specific nerve input. So, that myofascial expansion in the past were described just as other muscular insertion, like anatomical variant,
Mm.
but are not variants because they are always present and always in the same area. So
Mm.
they surely have a function because they are really constant and they always connect some specific portion of the muscle with some specific area of the fascia in a very precise way.
Mm. And so, apart from, say, being able to distribute force transmission over a larger surface area, do you think that also plays an important role with creating tension of the fascia, say more distally or proximally, that helps to coordinate neuromuscular function when we're doing, say, more complex movements like throwing a ball or running or doing something like that, where it tensions the particular chain or sequence associated with that movement?
Absolutely. I think that that is one of the key concept of fascia. So the fascia work like a very broad tendon
Mm.
that transmit the muscular force, but also connect different muscle that work in the same movement. until 1 century ago, the people started to speak about the muscular chain, the muscular connection, because we know that the different muscles work together for a specific function. But in the past, that connection was thinked only by the brain. Now we know that the fascia create really a connection like a chain among different muscles, and that has a strong anatomical basis. So more that myofascial connection work well, more the muscle can work in a synergic way, faster and more properly. More the fascia is disarranged, less two muscles are able to work in a synergic way. So for me, when we learn a new movement, we create a specific reinforcement that strengthens the synergic connection among two muscles.
Mm. And that to me really highlights the importance of specificity when we think of, say, movement or skill acquisition, where if you're trying to learn a particular task, you have to be careful not to break it down too much into, say, working just one region of the body, because you lose that mechanical input through the particular sequence or chain that over time reinforces the characteristics of the fascia that helps coordinate the recruitment of whatever motor units need to be recruited to help stabilize and complete the task.
Exactly. What we need to just to underline that sometimes we have a pretty thin person that
Mm,
have a strong, are very strong. They have an incredible plyometric energy. Other
yeah.
people that have a pretty big muscle that maybe are able to show to express less strength. And I
Mm,
think that is one of the elements that underline the ability of fascia to support the muscle in that synergic work.
yeah, I work a lot with sprinters, and it's amazing to see the different types of phenotypes in sprinters where you definitely get those people who are much leaner and wiry, but what we describe as being really elastic. Their ability to create massive amounts of forces when they start to create stretch shortening cycles is amazing, and that can often be expressed in terms of they may also be very strong, but they also are very good at doing plyometric work in terms of jumping, depth jumps, their ability to be able to store and release energy within their fascial network. And part of that obviously too has to do with how they can coordinate their neural and fascial and muscular system is quite incredible.
Exactly, because we know how the tendon are able to store energy and to
Mm,
support the plyometric contraction. But what we need to underline that the fascia is like a huge and broad tendon. From an histological point of view, is more or less the same,
mm,
but much bigger, because if we are able to use all the fascia of our upper limb are 1 meter of tendon. If
mm,
we use all the fascia of the inferior limb, and maybe also the thoracolumbar fascia, or maybe until the upper limb, we can have 2 meters of tendon that can store energy and give back energy. So, if we are able to train our fascia in the proper way, we can increase in an incredible way the amount of energy that our athletes can use.
And even just thinking about, say, sprinting, the forces we're putting through our body are of magnitudes greater than our body weight. We're looking at 5, 7 times your body weight, which, if you think about the muscle's ability to create force, no one can squat 5 times their body weight. So it really highlights the ability of the whole fascial network when we think about tendons, but even expanding beyond that when you think about the muscular fascia as well, has a great ability to be able to store all that potential energy from that ground reaction force, and then for people who can really coordinate it, release it as effectively.
Exactly. Is so really, I hope that in the next future we can really introduce much more the fascial concept in the training,
Mm,
because now I see that often we just strengthen the muscle, but we don't take care what happen to the fascia when we are giving so huge load and often in a very segmental way.
mm, mm. I am cognizant of your time, Carla, but if you've got time, there's a couple of more questions I want to ask you. And one of them, which ties into fascia, believe it or not, is the role of the retinaculum. Because this is, again, something that a lot of people may be familiar with, these retinaculum that are particularly prevalent through around our wrists and our ankles. But actually thinking about what role they have from looking at a histological perspective, the specific cells and organelles that we actually find in the retinaculum. Would you be able to describe what the retinaculum are and what physiological role they play?
The retinacula are reinforcement of the fascia around the joint. So is nothing different respect to the fascia. Is just the fascia that is stronger, more organized, with more collagen fiber, with an oblique direction to reinforce the coordination between inner side and outside of the joint, to organize the rotation movement, the spiral movement around that joint. And again, the retinacula are more innervated respect to the other part of the fascia because they need to feel the movement much more. They are in an area where the movement is important, so also the amount of nerve endings is much more. And
Mm,
finally, the retinacula have much more hyaluronan respect to the other fascia because again are in an area that need to move, and consequently the amount of hyaluronan is more. So the retinacula is like an hyperspecialization of the fascia
mm,
to perceive and to support the movement in the best way.
mm. So when we think about the sensory or proprioceptive role of the fascia, the fact that we have this highly organized retinaculum around the hands and the wrists makes sense because when we think about our interaction with our surroundings, it's through our hands and feet. Ultimately, we coordinate movement to put our hands or feet in certain positions to complete certain movements.
Exactly.
Mm. And so, like, again, thinking about doing a complex movement like throwing, we're winding up our body and storing and releasing energy, but ultimately, the a key area to it has to do with the tension being created through the retinaculum that provides the feedback to help coordinate the elbow and the shoulder and the trunk, in the
Yes,
example of
but
throwing at
it's
least.
important to remember that the retinacula is not an isolated structure, but is
Mm-hmm.
totally in continuity with the fascia that are above and below.
Yes.
So, because in the anatomical textbook they are drawn just as like ligament only in that area. It's not true at all.
Mm-hmm.
They are part of a bigger system, and
Mm.
in that part they have hyper-specialized.
Mm. And would you be able to talk a little bit about their involvement in, say, injury? Because I know there's some research that has been done with regard to looking at, say, chronic ankle instability in the retinaculum. Can you discuss that?
Yes, we published a paper about the alteration of the ankle retinacula in chronic functional instability. The chronic functional instability is a very funny pathology because the patient feel the ankle that is unstable, but when we test the ankle, usually it's more rigid and not unstable at all.
Mm,
So is the proprioception of that ankle that is not working well. And in that specific type of patient, we found many different alterations of the retinacula. We found some interruption of the continuity, some edema, some thickening. some fibrosis, some adhesion with the surrounding tissue. So again, probably we need to subclassify better the alteration of the retinacula. But what is sure that the retinacula could be affected after ankle sprain, and if they are not restored in their anatomical structure, microscopic structure, probably they don't allow a good proprioception of the area, and consequently they can create a functional ankle instability and a recurrent ankle sprain.
Mm. So again, this really highlights that in a dysfunctional or pathological retinaculum, unless we find strategies to be able to restore its normal function, you're going to have that altered input in terms of how the muscular system is coordinating and contracting to actually stabilize the associated joint.
Yes, I think that again, we need to move further respect to consider just the muscle that stabilize a
Mm,
joint.
mm,
They are part of the system, but we need to have a good fascia, good retinacula, many different elements that need to work for that.
Yeah, I often think about the muscle as being the final product or the output, in that it's clearly muscle is very important for obviously locomotion, stabilization, all of the above. But how the muscle is contracted and recruited is dependent on the input from the peripheral nervous system, or sorry, from the peripheral, the tissue system. So if we have alterations to the peripheral system that affect the afferent feedback going to the central nervous system, that's going to influence the ability for motor units to be recruited. And if they're not recruited properly, alter or create non-optimal coordination strategies. You think that's a
Exactly.
fair assessment? Yeah.
Yes, exactly like that. So the muscle is what is able to create the movement,
Mm,
but to create the movement, we need to have a good nervous input, good
mm,
sensory element, and a good environment that allow that movement.
yeah. A question we always like to ask our guests to finish up is there anything that you're exploring or learning about that you're interested in outside of your professional career? Because it's always nice to hear about what people like yourself, who obviously have such knowledge and expertise in one area, to think about what other things that you do outside of work, or do you not really get much time to do that?
I think that the second one, because I have a lot to work. I have two children to and a
Sure.
family to organize, and is pretty hard to find the time for other
Mm,
things. I like theater. I like it well. I like to visit different city, country. I like to work.
mm.
But I need to have much more time to do all what I need.
Well, speaking of travel, actually, I know that you're coming to Australia very soon to present at the World Congress of Lower Back and Pelvic Girdle Pain, which will be great to have
Yes,
you and to see your research. I know you're doing a workshop as well, which will be fantastic.
yes, I'm very excited to come in Australia because I that conference for me is really an important conference. We need to speak about back pain and how to manage the back pain. The back pain is a very dramatic disease because it can create a huge cost for the society, huge limitation for the patient, and actually we are not able to treat in the proper way the back pain. So we need to discuss, and that conference surely is a good point, a good moment to meet all the experts about back pain of the world, to understand how we can move forward. And come in Australia is my second time there. I was never in Melbourne, so I'm very excited about.
Yeah, no, I look forward to seeing you present your work, Carla. Thank you very
Okay.
much for coming on the podcast and giving up some of your time. And yeah, I look forward to continue to see what work you produce in the future.
Thank you so much. Thank you to you for the nice interview. and
All right.
bye bye.
Bye.